everyone. Thank you for joining us. I can see there's quite a few people here, but I can't really see any of you. A few of you have popped up and given us a wave, which is great. It's really good to be back at bite-sized sessions again after having a summer break. My name's Rachel Stevenson. I'm CEO of Reverse Rett, and I'm here today with my colleague, Beth Johnson, also from Reverse Rett. Both of us are parents of daughters with Rett syndrome, as well as being here in our Reverse Rett roles. This is obviously a live and interactive session. It will be shown afterwards on YouTube and so on, so please keep that in mind. And although we want you to interact, we do ask that you keep your mic on mute unless and until you're speaking. If you'd like to ask a question as we go along, you can put your hand up, or you can put your virtual hand up, or you can write it into the chat, and Beth and I will pick it up. I like picking questions up as we go along so that people don't get lost. But equally, we can ask questions at the end, or you can ask them directly at the end, which we certainly encourage you to do. Today's speaker is Dr. Girish Sharma, Professor of Pediatric Pulmonology at Rush University in Chicago. We're really grateful to Dr. Sharma for joining us today. It's still early on a Monday. It's also, not only is it early on Monday, it's actually a bank holiday in the US today. And I see someone else from the US has popped up to say hello from Michigan. I think it was Greg. Hi, Greg. I can't believe Dr. Sharma has been willing to do this today on a holiday, but I'm really grateful for that. Dr. Sharma is an expert in pulmonology, which means all things related to the lungs and respiratory systems of children. And he works with children with a broad range of conditions, but has a special interest in Rett syndrome. I first met Dr. Sharma earlier this year at the Ascend conference in Nashville. I went to listen. I didn't listen to all the sessions in Nashville because some of the things I thought, well, is there anything new I need to save my brain for the sessions where I'll really learn something different? But I went to see Dr. Sharma because I know from my own experience, and also from talking to lots of other UK families, that it's very difficult for families of people with Rett syndrome in the UK to get appointments with respiratory medicine or a pulmonologist. And actually, we're a lot of the times really disregarded by this discipline. And I was really blown away by Dr. Sharma's presentation and the manner in which he presents as well. And I will let Dr. Sharma share with you the kind of information which led me to chase him down in the lunch line and provide a session for us. But the most important thing, I think, was that there's a real emphasis on preventative measures, which we've really not been told enough about in the UK, I think. Those preventative measures that can be put in place to support the ongoing health and safety of people with Rett syndrome, even before you become aware that they are somebody that will struggle with respiratory issues. So with that said, Dr. Sharma, we are really grateful to you for joining us today, and thank you for giving us your time on this day off. And if you are ready, I will hand over to you.
In the special situations, what were the strategies and devices we used to prevent or delay the complications in these patients? And what is the time for referral, admission, procedures, and such as sleep study, video follow study, or the assisted ventilation, and even trach in these patients. And then, of course, we'll talk about the special situations when, for example, when the patient intervention, such as sedation and anesthesia, what are the precautions we're supposed to take? So before we go ahead, this is a list of the breathing abnormalities which have been seen in the patients with Rett syndrome. And so whether we talk about the classical type of Rett syndrome or the atypical type, 80% of them are reported to have breathing dysfunction, which is clinically present. In fact, there's by investigations, virtually 100% will have some abnormalities at some stage. The peak time for them to have problems is around 6 to 11 years. Then there is a kind of remission time for next 2 years, 11 to 13. And then, of course, worsening can occur at any time in the age. And problems are during the sleep as well as during the wakefulness. In fact, some of the problems, as we will discuss, are worse during the wakefulness. So reported breathing problems are hyperventilation, basically fast breathing, which can be episodic, can occur irregularly, breath holding, which is up to 30 to 45 seconds, which is a pretty long time if you think about it. Apnea is like a breath holding after a normal inspiration. And as I mentioned earlier, respiratory dysfunction during wakefulness and sleep time. And they can have low oxygen level in the blood due to the impaired gas exchange, and there is increased oxidative stress. These days we talk about the antioxidants, etc. And the air swallowing, which is very common in these patients, can lead to bloating and discomfort. Other problems which may affect the breathing indirectly or directly, we talked about the sleep disorder breathing and night laughter, screaming spells. Scoliosis is the curvature, abnormal sideways curvature of the spine, and gastroesophageal reflux, swallowing abnormalities, hypersalivation or the drooling, which can lead to aspiration of the secretions, leading to pneumonia. And there have been reports of having breathing dysfunction in patients who have cardiac problems such as prolonged QTC interval. So to explain to you what happens in these patients, I'll use this paradigm of respiratory balance. So imagine this is a respiratory balance hand here. I hope you can see my mouse. And on this limb, you have the components of what we call a respiratory pump, and which is constituted by the characteristics of the ventilatory muscle, respiratory muscles, their power, their tone, and the breathing pattern. And this component works against this kind of part of the balance, which means the pulmonary mechanics. By that I mean, what is the resistance to the flow of air which goes through the airways? What are the upper airway properties, like supposing you're talking about the hypotonia, the low tone in these patients, which causes the increased resistance. So normally there is a balance between these two limbs of this balance, respiratory balance, and there is an adequate ventilation. But in patient with Rett syndrome, if you have abnormalities in the muscle characteristics such as the low tone, which is hypertonia, they tend to have very commonly, and then later on it can convert into rigidity. Then the breathing abnormalities in terms of their irregular rate, rhythm, breath holding, etc. And so this respiratory pump component is affected. This limb is raised up and this limb goes down, and that is also contributed by the mechanics of the lung in terms of scoliosis causing the restriction to the expansion of the lung, aspiration of the secretions from the upper airways into the lung causing pneumonia, etc. And the upper airway properties are being abnormal, such as low tone causing the collapse of the airways that causes more resistance to the flow of the air through that. So in that situation, then you end up with the respiratory insufficiency. Okay. So what are the consequences of these pulmonary problems? If you look at that, this is described within this flow diagram. And on the first look, you will find it very daunting, but don't worry, I'm going to walk you through this in components. So let's talk about the main problem being the hypotonia, associated weakness, breathing abnormalities, This leads to the restrictive lung disease. By that I mean that lungs behave like a balloon. Like if you want to inflate the balloon, you have to force air in it. Similarly, the breathing in process in the body is an active process when you have two major muscles which are for inspiration. Your diaphragm is the main inspiratory muscle and the external intercostal muscles. So the contraction of these causes the expansion of the lung. So, and like a balloon, if you want to deflate it, you want to empty it, just leave it alone. Automatically the air will come out of it. Same thing happens with the lung also. The breathing out process is the passive process. These diaphragm, which is like a dome shape, goes, and when its contact goes down and flattens and creates like a negative pressure. And similarly, in intercostal muscles, the muscles which are in between the ribs, they expand the chest, and when they relax, the volume reduces. So this process is restricted because of the low tone there. In addition to that, we can have ventilation perfusion mismatch, V/Q mismatch, and I'll explain to you. So imagine when you breathe in and out, you take air from your nose and mouth, which goes through your windpipe, which is in the neck, the trachea, and the trachea divides into bronchial tubes, which are like branches of a tree or the roots of the tree. And as you are going deeper into the lung, they become more and more branches, and they become thinner and thinner. So imagine my neck is one branch, large branch basically. My arms are the medium-sized branches. My fingers are the tiniest branches. And you're imagining that the air is traveling through these tubes. At the end, where my nail is, that's where the alveolus or the respiratory unit is there. That's where the air exchange happens. By that I mean, on one side of a membrane, you have the air, and the other side is the blood. So normally what happens, the air part is the ventilation and the blood part is the perfusion. So there has to be a match where what happens, the oxygen from the air goes into the blood and body produces carbon dioxide, which is like which comes back into the air. So when you're breathing in, you take air with oxygen. When you breathe out, you give out carbon dioxide. So this process is affected if you have pneumonia, if you have secretions collected there, if there's inflammation there, infection there, etc. And all these things can cause the alveolar hyperventilation. By that I mean the carbon dioxide level starts building up in the body. And as I told you, the air goes through these tubes, and if the air is not able to go adequately, there is a collapse of those tiny units there where the air exchange is happening, which causes the microatelectasis. Atelectasis basically means the collapse of that part of the lung. And that causes increased work of breathing, which again causes the hyperventilation, and that means that CO2 is elevated, and which is contributed by the scoliosis also. Now, if we add another component to this, which is the low tone in the upper airway muscles, collection of secretions there, and that can lead to sleep disordered breathing. As you know, when you're breathing, especially in the rapid eye movement stage, REM stage of the sleep, the whole body goes floppy. But if you already have a low tone, that's going to be worse. So that causes the obstruction to the flow of air through the airways, and leading again contributes to the alveolar hyperventilation. Then of course, this low tone causes, like when your secretions are there in the lung, or you're eating or drinking, normally your passage to the lungs, the glottis, the voice box, that tends to close. The vocal cords are closed so that nothing trickles down through those vocal cords of the glottis. And that can be affected because low tone. So with the result, the secretion tend to go into the trachea and can cause like a collection there, airway obstruction, again contributing to the increased work of breathing. Okay, and then we add one more component that if low tone and can affect the efficacy of the cough. So normally you got some secretions in the throat, you cough it out, or they go down into the windpipe, you cough them out. But that may not happen effectively because in these patients because of the low tone and the muscle weakness. And that can lead to secretion being collected there, or rather being aspirated, causing the pneumonia, and then again causes the alveolar hyperventilation. So at the end of the day, we have a combination of this restrictive lung disease, ventilation perfusion mismatch, parenchymal disease because of the pneumonia or infection, sleep disordered breathing, increased work of breathing, and the alveolar hyperventilation. And all these things contribute to the chronic respiratory insufficiency in these patients. Okay. Now, this is a study which looked at the sleep disordered breathing in patients with Rett syndrome. And they had 13 patients, and they're talking about snoring present in 70% of them, and witnessed apnea, like somebody saw that the patient stopped breathing, and that was in 54% of the patient. Hypopnea, which basically means the reduction in the flow of air into the lung, and that was followed by the central apnea, even during wakefulness in 100% of the patients. So that is a pretty impressive, like all patients showed this, but this was a small study, minded. Then of course, 70% of them had obstructive sleep apnea. By that I mean obstruction of the air flow through the airways. It's like if you are drinking some thick milkshake using a kind of a very floppy straw. And so what happens, it tends to collapse as you create a negative pressure by sucking. And if it is a real lousy straw, very collapsible, it completely closes and nothing comes in the mouth. The same thing is basically happening here, that obstructive sleep apnea causes complete cessation of the flow of the air into the lung. Then there will be a lack of signal from the respiratory center and patient stops breathing. That's the central apnea. So the obstructive sleep apnea, much higher percentage, 70% of patients showed that. Central sleep apnea, only 8%. And this can lead to low oxygen level, and normal level you're talking of 93 to 100%, and we can buy up to 90%, but here they reported 88% oxygen saturation in the blood. And then they talk about the treatment used and when to suspect. I'd not go into details because that was their study. Let's go to the what happens during the wakefulness, the breathing dysfunction that time. So there are reports of erratic breathing, which may be episodic, hyperventilation, and irregular breathing, which can be shallow and or forceful, breath holding, which we talked about earlier, is episodic, and it's not because of the signal is not coming from the brain. It is not related. It can't be called a central apnea, but patient holds the breath. Okay, and typically what happens, the breath hold begins with an apparently normal inspiration. Then there's after that there's a brief post-inspiratory phase where the heart rate decreases, and then actual breath holding phase starts when the heart rate increases. This is another study by Difflis et al., and they talk about the apnea, hypopnea, and other sleep problems in these patients. And so, as I mentioned, apnea is complete cessation of the airflow and for more than 10 seconds. And hypopnea is shallow breathing where the flow is reduced by 20% or more. And we're talking of the during the sleep time, you're talking of the obstructive sleep apnea. And these are the median number of events per hour. How many events happen per hour? So you're talking obstructive apnea, 6.2 events. Central apnea, 0.4. Mixed apnea, 1.5. And hypopnea, or the reduction in the flow, in 25%. 25 events per hour. And if you compare that with the wakefulness, what they reported obstructive sleep apnea was 17.7, which is much higher during the wakefulness. So this is very interesting, very intriguing finding, which doesn't happen in the other situations, such as muscular dystrophy or any other patient. Okay. Central apnea, comparable between the sleep and the wakeful time. Mixed apnea, not much different. And hypopnea also, or the slow flow, reduction in the flow, also comparable. Okay. So they summarize that obstructive episodes are more prevalent in patients with Rett syndrome. Obstructive episodes are more during wakeful time than the sleep time, and they reported, or they observed, the low oxygen saturation being as low as 78.8%, which is much lower, because when talking of 93 or more, normally if you check yours or anybody, we are like in 93, 95, 97 or 100%. And sleep apnea reported in 63.6%. Mean AHI. AHI is the number of events, like apnea, hypopnea index it is called, and how many events, such events happen in 1 hour. And normally in children it's 0. In adults, we take it up to 5 being normal, and after 5 we call it abnormal. And they found the AHI in these patients, the value was 15.9, for in mean was 15.9. And if the AHI was 15 or more, then the obstructive sleep apnea was 27.2%. Okay. Then another problem, as I told earlier, that because of the low tone, because of associated weakness, there is poor and ineffective cough. So that leads to the pooling of secretions. They get infected, cause pneumonia, inflammation of the airways, which leads to the bronchial hyperresponsiveness or the twitchiness of the airways, and present like asthma kind of a presentation. Okay, and then of course it can lead to the chronic respiratory insufficiency, as we saw before, respiratory failure, and this is the situation where we're going to need, the patient is going to need some kind of assisted ventilation. Okay. So one of the major advancements in the management of these patients has been the airway clearance, because as we talked earlier, you have ineffective cough, you have secretions, you need to get rid of the secretions. And if the cough is not effective, we need to help these patients by using certain devices. And before I go, I just want to briefly kind of review how do we cough. So when we are coughing, what we do is to, depending upon our intended effort, how strong we want the cough to be, we take a breath in, and that in, you take a big breath in, that time your glottis or the vocal cords are going away from each other, so that the opening through which the air is going, that becomes wider. And then this glottis closes, and the next stage, the compressive stage starts. When we use those muscles which are supposed to force the air out of the lung, accessory respiratory muscles, they are involved, and you create a kind of positive pressure inside the lung. So if you think of it, the pressure is not inside the lung only, it is around those bronchial tubes also. So what happens, they tend to compress, the reduction in the caliber of those tubes. For example, your trachea or the windpipe can reduce its caliber by 80% during a forceful coughing. Okay, and with the result, the secretions which are stuck to those walls, they tend to loosen up, and what is happening now? The vocal cords are closed. You below that, you have this positive pressure building up, and the other side of this vocal cords is a normal atmospheric pressure. So basically, there's a pressure gradient between the two sides, like a double door which is closed, and somebody is forcing its way through this door. And in the beginning, there's a resistance, and eventually, because of the buildup of the pressure, and the air gushes out of that vocal cords. Okay, so what happens? That flow, which can be as high as 14 liters per minute, And the speed, the velocity, the air comes out is amazing. You'll be surprised if I tell you that that is the velocity to the compared to the sound velocity is 2/3 of the sound velocity. So we are talking of 25,000 centimeters, while the sound speed is 34,000 centimeters per second. So we're talking of very high speed, and that's how you cough out. And this is affected in these patients. And what do? We use this device, called mechanical insufflator exsufflator. Basically, in a nutshell, this device is forcing air in your lungs and sucking it out. And on this side, you see that we set the pressure, at what pressure the lung will be inflated, that it will be forcing air, at what is the negative pressure it will create to suck out the air, and that's the expiratory pressure. Inspiratory time, how long it will be inflating the lung, how much time it will take to exhale, and then how many breaths in one cycle, like that we do. So what we do is usually we use a bronchodilator, which opens the bronchial tube. With the result, the secretions which are stuck there, they kind of get loose. And then we are using this device, and this, you see the picture there, and you can see the tube coming out of that, which is attached to a mask which goes on the face of the patient, or the tube can be connected to the endotracheal tube if the patient has got like an endotracheal tube is the tube in the trachea for ventilation purposes, or if the patient has a tracheostomy, it can be attached to that. So this device was pretty old model, and this has been pretty heavy. It was like a 28 pounds, and now it is replaced by a current version, which is like a 8 pound only. The first one you saw that knobs and things like that. Here you have a digital control, so chances of what you call something going wrong, erratic, somebody knocks it and then the changes, settings change. That is not possible with the new one. And basically this device, what it does is, as I told you, it increases the flow of the air out of the lung. It improves the efficacy of the secretions extraction from the lung, and definitely helps to prevent the recurrent respiratory infections. And moreover, since it is forcing air in the lungs, it is opening the airways which are not usually open. So it's called lung recruitment, and that's very helpful for the ventilation purposes. And then, of course, as it is forcing air in and out, it is moving those joints, the rib joints and the vertebral joints, with the result that the stiffness is reduced or the delayed, and that stiffness can cause restrictive lung disease. So basically, you are slowing the progression of the restrictive lung disease by just using this device. In addition to the main purpose, this device is used for the extraction of secretions from the lung. Okay, and I will show you this video in being used in one patient. And these are the pressures we just set in: inspiratory pressure, and the tube is coming from the device, is on the mask, and is forcing air each time and sucking it out. So the blue one is the breathing in, and this is breathing out, and these are the pressures, timing, and the pause, etc. Okay. And this device is wonderful because imagine this patient, for example, who had very poor cough, could not cough, and we suspect as a mucus plug. And we use the device, and you see this.
You're so used to it, you're not going to be able to beat you at it. Yeah, he kind of sticks his tongue out. He's got used to it, Mom. He knows how to talk. Okay, there you go. There you go. You got some.
Look at this.
Hold on.
So we got a big blob of phlegm which was stuck in the bronchial tube. We were able to clear it, and otherwise it will be causing problems. Okay. Now, for example, this is a patient with neuromuscular disorder. You can see the ribs here, heart here, all lungs, and this side is all white. The general principle in the X-ray is that the air looks black, and if there is no air, it looks white. For example, heart part here is white, liver is supposed to be here, all white, if you can see the white, and this white, white out here, it looks like there's a pneumonia there because it's all filled with phlegm. But when we use the cough assist device in this patient, within 2 hours, the same patient, the picture changed completely. Look at this here. So all that white out which was there is gone. Lungs are much better inflated. The heart and the ribs and everything else is much better defined because there is more air now. Okay. So that cough machine does wonders. So far we talked about the mucus extraction, which is the main thing. Definitely it helps you. But if the secretions are thicker, and then there's another process which is called mucous mobilization. It's like a ketchup stuck in the bottom of a bottle, and it's thicker because very little left and stuck to the wall and all. And what do? You shake it first. You shake it, thump it, then you put the bottle upside down and thump it again so that ketchup comes out of the bottle. So that's what we do by this different technique called mucous mobilization. And for that, we use this device called high frequency chest wall oscillation. So high frequency because it is oscillating or compressing the chest at certain frequency, and idea is to mobilize those secretions. So it has got 3 components. You got an air pulse generator here, a device, and then which is attached to these tubes are attached to this device, and the other side of the tubes are attached to an inflatable chest, which is wound like a vest on the chest. So it's like forcing this air in and out by, not wrong word there. No, it is oscillating and shaking the chest, thereby mobilizing the secretions. And I'll show you the video of that also in a second. These are the settings for this device. We want to set what frequency we want. What is the inflating pressure? We want to individualize it to make it comfortable for the patient, at the same time efficacious so that it works. And how long do we want to do that? Okay. And here is the device here. You can see the hertz, like a frequency, what is the pressure there, how much that we want that, and this tube is coming out of this tube of the device and will be going to a vest attached to the patient. So see, you can see it's shaking there. You can see it's shaking more obvious. And this tube is attached to the vest, which is attached to the wrapped around the patient's chest and mobilizing the secretions. Again, we use this device more commonly in patients with the cystic fibrosis who tend to have thick secretions, but neuromuscular patients also, some of them we have to use it because the secretions are always thicker there. Okay. Other issues with these patients have is the swallowing issues. And by that I mean the swallowing is affected because of the Rett syndrome causing the hypotonia, low tone, and the muscle weakness. Swallowing is a complex process. We're talking of 26 muscles with 5 cranial nerves involved. And there are 3 phases of swallowing. First is the oral phase, where the food is broken down and you're chewing and you're trying to make a bolus. Okay. And second phase is a pharyngeal phase. Then this bolus is pushed to the back of the throat. And if you have issues such as Rett syndrome, for example, low tone, malocclusion, things like tongue movement and the oscillations of the tremors in the tongue, etc. All those things affect this first stage and the second stage. And then, of course, the third stage is where this food is pushed into the esophagus, and that again there may be absent motility waves there. Patient swallows air, which is aerophagia, which is associated with the mouth breathing. A patient have gastroesophageal reflux or sensory deficit, or they can have an intolerance to certain textures. All those things lead to the poor coordination between breathing and swallowing, and especially if the patient has got apnea, etc., with the result the swallowing is affected. So what happens? So normally when you are eating and drinking, this is your esophagus and the marked with the red arrow there, and the food is supposed to go this way, and this green arrow points the vocal cords or the glottic opening, which closes when you're eating and drinking, so that there is no aspiration. But here in these patients, because the low tone and all these abnormalities which I discussed earlier, this is the incompetence, there is an incoordination, oropharyngeal incoordination, with the result some of the food tends to trickle down to those vocal cords, cause aspiration. And if the anything goes through the vocal cords, it is called penetration. But if it trickles down and goes into the lung, which is the lung, that's called aspiration. And that cause is pneumonia and all. Okay. And I'll show you this video, and it's called video swallow study. So what we're doing is we are making the patient swallow this. We are feeding this material, and you'll see that will be as a dark shadow here, and most of it will go into the esophagus, and some of it will be spilling into the trachea, which is in front of that. Let me play this video. See, you see that black color here, and the food is going. So you can see that this is going into the esophagus or the windpipe. But you see, this is a little dark color in front of that. That's the part which is going into the trachea. So this is frank aspiration in this patient, and this is a bad situation. And if that happens, you end up with pneumonia, recurrent pneumonia, etc. So what do we do about this? So we try different kind of consistencies in these patients. We see if the patient is intolerant to everything, whatever we feed, whatever consistency food, whether it's the pureed or the honey thick or the water, everything goes there, or only the very thin liquid goes through the into the lungs. And depending upon that, we may have to decide that, okay, we put a little placement of this, what we call a G tube, which is goes into the stomach of this patient. And for a long term, we tend to replace it by the G button. So this goes into the stomach here. You can see it in the top outside, and this is inside, anchored by a little inflatable balloon there. And then we can use it for feeding only liquids or all the food, depending upon how severe was the aspiration or the dysphagia or the issue in this patient. Now, in some patients, there is a gastroesophageal reflux also. The stomach acid comes back from the stomach into the food pipe, which goes into the back of the throat, and patient aspirates that. And if that situation is there, then we use this fundoplication, like we create a valve there by pulling this part of the head of the stomach around the esophagus and stitching it there. This is a fundoplication, and that avoids the regurgitation of the food back into the esophagus and causing complications, etc. Okay. Other pulmonary abnormalities reported in these patients. And I want to draw your attention. This is a study by Deflis et al. Presented some time ago. But main thing was, among other changes which they saw in the high resolution CT scan, was this bronchitis. And by that I mean, remember we have been talking about the infection, the bronchial tubes, pneumonia and all. And that infection causes the it's mediated by the neutrophils or the white blood cells. And these white blood cells, they release the enzyme called elastase. And elastase ASE, A is basically in medicine means that is splitting or something. So elastase, as the name suggests, it digests the elastic tissue, which is keeping these bronchial tubes taut normally in a shape. And if the elastic tissue is destroyed, they balloon up actually. And if they balloon up, you see the secretions collect in this balloon. They're difficult to clean, and that kind of causes more problems and recurrent respiratory infections, etc. Okay, and other abnormalities this guy has reported at different times was the increased AA gradient. Remember we talked about the air exchange on one side of a thin membrane having the air, other side blood. So capital A is the oxygen in the alveolus or the air, and small a is the oxygen in the blood. So that can be abnormal. Normally, there's a balance there, but that balance may be imbalanced in these patients because of the bronchiolitis in 50% of the patients. Pulmonary gas exchange abnormalities reported in 228 patients. And they found that there was respiratory dysfunction at some stage in 100% of the patients, and which was moderately severe up to 80%. And VQ abnormalities that which we talked about so far, and more obvious here. So in this graph, you see the black dots show the air exchange, and the red dots line shows the blood. So black one is the ventilation, red one is the perfusion, and normally there has to be a match between these two components. So here there's a low VQ measure. The ventilation is low compared to the perfusion, and this is in 28% patients. Then there may be other way around, high ventilation perfusion ratio. So the ventilation is higher than the perfusion there. And the other abnormalities, they may be simple mismatch. They are at the same time, but still they are mismatched, or they are mixed. So one is early, one is late. So these are all abnormalities which are not obvious unless we look for it, and they may be going in the lungs. Another issue with these patients is that all these problems which we have talked about so far, they cause problems not only for the patient, for the family also. And this is the burden of illness. What happens? Like we're talking about the feeding difficulties, aspiration. This patient will need feeding, supervised feeding, some help with the feeding, and may develop malnutrition. Sometimes when they are air swallowing, leads to bloating, which will cause discomfort. Feeding difficulties can lead to malnutrition, and sleep issues we talked about in the sleep. In addition to what we talked about, there's as you know, laughing episodes are common, screaming spells are common, apnea, sleep disorder breathing. All these things will lead to the sleep disturbance, not only for the patient, for the family also. And that leads to kind of disruption of the sleep for the family. And the screaming spells, family think there's a patient in the pain, or the sleep, they can't sleep because of that. And again, dysphagia, we talked about aspiration, pneumonia, they can lead to admission with pneumonia, oxygen requirement, need for antibiotics, need for airway clearance on a regular basis, use of one of those devices which we talked about. And this all leads to the economic and social burden on the family. And based upon these, we had done a study. We just published that in International Rett Foundation conference in Nashville in April. And it was a multinational study, and we had more than 700 patients of Rett syndrome across 5-6 countries. And again, we highlighted the importance of this impact of respiratory abnormalities on the family and the patient in terms of disruption of daily routine, sleep, social life, need for training to handle various techniques and devices, need to take those days off for acute sickness care or daily therapies, or take the patient to the hospital, etc. And sometimes there's so much stress that they can't handle it. Actually, some people leave the job. There's some family dynamics abnormalities there, and other siblings may be neglected because the one is getting so much time on the part of the family and the parents, etc., the care provider. And all this leads to the economic impact because of the need for equipment, need for medication, taking time off the work and travel, etc. Okay. So if there is a chronic respiratory insufficiency, we need to help these patients by providing them assisted ventilation, which can be of two kinds. One is the invasive ventilation, when we have to put a tracheostomy, like a hole into the trachea, and you are attaching to the ventilator. But more commonly and more easily, and the first approach is the non-invasive ventilation, where we have shown that it improves the quality of life. It helps with the reduction in the sleep disorder breathing problems, and definitely reduces the apnea, hypoxia in the night, and hypercarbia. Hypercarbia is elevated CO2 levels. Okay. And non-invasive ventilation can be short-term in a situation, let's say somebody develops a respiratory infection and needed a little help with the ventilation that time, or in a chronic respiratory insufficiency situation, patient may need the assisted ventilation during the sleep only. And sometimes it depends upon, we give them the choice whether for in situations which is like a borderline for invasive versus non-invasive, we go by the parental choice or the provider's choice and the patient's choice, what they can tolerate and what would they like to have. And then different kind of interfaces we can use. The mask is the most common thing, which can be like only on the nose, or only on the face, or nose on face both, or the whole face mask. The different kind of interfaces there. Okay. Then the modes can be as simple as what we call as CPAP, continuous positive airway pressure. So basically, think of a collapsible tube and you're blowing in this tube. So this is what CPAP is. And people like me with the sleep apnea, we tend to use a CPAP. So there's a device which is attached to a mask which you are wearing, one of those interfaces which we talked about, and it's forcing air into the lung at a certain pressure. Or we can change the pressure to a bi-level, because during inspiration is a high pressure, during exhalation is a low pressure, so it's a BiPAP device, so two pressure there. And then of course we can add to kind of a timing also on that, to add the breathing part basically. And in this, now we're talking the assisted ventilation using the pressure mode or the volume mode. Pressure, where we're deciding the pressure, how much pressure we want, or the volume, where we want to we target a volume, and we put the settings to ensure that volume is delivered. And there's another mode called pressure support. Pressure support basically means we are supporting each breath the patient is taking by an extra pressure there. So it's a pressure support. And there is a mode called AVAP, like average volume assured pressure support. So basically what we're doing is we're deciding, okay, this patient needs 500 cc of air each time he breathes in. And we tell the ventilator, okay, this is your upper pressure limit, this is the lower pressure limit, and it can go between this range and provide this. So ventilator takes care of that. There's another mode called intelligent volume assured pressure. So there we are targeting the alveolar ventilation. Remember we talked about the most peripheral part where the action is happening, the air exchange is happening. So we decide, okay, we calculate or we decide how much ventilation we want there. And excuse me. And we put patients' height, weight, and other parameters to decide and tell the ventilator, and ventilator makes sure that that much alveolar ventilation is assured with each breath. Then there's another mode called synchronized intermittent mandatory ventilation. So basically the ventilator is synchronizing the breath with the patient's breath and giving extra breath there. Assist control is when the ventilator is giving additional breath, which is irrespective of patient's requirement that time, or mechanics in the lungs, etc. And all these can be, as I said earlier, it can be volume cycle or the pressure cycle. So there are different modes of non-invasive ventilation. But at times, non-invasive ventilation is not sufficient. And or there's some issues with the institution of the non-invasive ventilation. For example, a patient doesn't tolerate the mask on the face because it's a super sensitivity, or patient or the provider would like nothing on the face for a long time because it will interfere with the speaking, it will interfere, which is not very common anyway. Having said that, the smile, you don't want anything on the face, those kind of things. And then of course patient is not able to maintain normal oxygenation by non-invasive ventilation. That's where we kind of offer this invasive ventilation using the tracheostomy. And advantage of tracheostomy is that it is easy during the sleep, no issue with the feeding, and the devices such as the cough assist device or the ventilator can be attached to the tracheostomy. The face is not affected or not involved basically. So it's a matter of choice, but by and large, majority of the patient prefer the non-invasive ventilation, and majority of the time we don't have to use the tracheostomy. But if we have to use it, we have to use it. Another situation we talked about earlier, what do we do with these patients where they're going for procedures such as, let's say, G-tube placement, or the, like we're talking about any procedure like a scoliosis surgery, etc. So our recommendation, which we published as guidelines from the American College of Chest Physicians in 2007, and we highlighted the importance of using the cough assist device if they're not using it before, making them use it and making them conversant and tolerate it easily. And more importantly, if the patient has been on the non-invasive ventilation, we want to make sure that is continued after the patient surgery is over and they extubate, they take the tube out, patient needs to go on the non-invasive ventilation. And then, of course, we very much emphasize the importance of aggressive airway clearance, much more than what was the baseline, and as soon as possible. And for that, we recommend controlling the pain adequately, otherwise you'll not be able to use those devices. When do we want them to be referred to us? That is ideally shortly after a diagnosis, because that way we can talk to the family or provider and give them anticipatory guidance, what to expect at what stage and what is coming in future. Then, of course, we would like to see them on a regular basis to monitor their pulmonary status, to definitely before proposed surgery, sedation, anesthesia, etc., and definitely in case of acute problems such as acute respiratory infections. Those of you who are interested in knowing more kind of details in terms of management of these patients, these two publications, one is which I was part of, publication for this American Academy of Policy Manual, which is a textbook basically being published by the American Academy of Pediatrics this December. There's a chapter on the pulmonary complication of neuromuscular disease, and all these general principles there are a little more in details in this article. And then, of course, we are just publishing the guidelines for the American College of Chest Physicians for the management of respiratory failure in patients with respiratory weakness or neuromuscular weakness. So what I did in last 45 minutes or so is to discuss what are the respiratory problems in patients with Rett syndrome. Why do the respiratory problems occur? How do we diagnose the respiratory problems? What are our strategies and devices used to prevent or delay the complications? What is the optimum time for referral for admission for these procedures such as sleep study, video swallow study, assisted ventilation, etc. And what do we do in special situations such as sedation, anesthesia, and surgery, etc. So I would like to thank Reverse Rett organization and all the members who attended today and who are going to watch it later on. And definitely the subspecialist in the multidisciplinary team at my institution at Rush, and definitely my patients and families. These are my email addresses if somebody has any question later on, but otherwise I'll stop here and will be happy to answer any questions which may be. Okay, thank you very much.
Thank you so much, Dr. Sharma. That was so interesting. And I'm glad that I've got to hear from you twice, because I think there's a lot of information in that presentation. But I think the key thing for me is that you are able to really demonstrate to people what the connection is between the everyday breathing irregularities that we see in Rett syndrome and these respiratory problems that people deal with so much of the time. I do have questions, but I see Yvonne has her hand up, so I will hand over to Yvonne. Yvonne, go ahead.
Can you hear me?
Yep.
Yes,
yep.
I can hear you. Yep, we can hear you.
Thank you. So I was a bit late joining. I had technical problems, let's say. Just very quickly, is it okay just to ask a specific question about my daughter, which may be helpful for other people as well, but I don't want to take up time. Is that all right?
Yep.
Right, okay, so my daughter, just background, my daughter's 42. She fed by mouth until 3 years ago, when she had a terrible episode of pneumonia, was very, very seriously ill, and she's now totally peg fed. We use a vest. We use the vest twice a day for 10 minutes each time. And we also use something called an LVR bag to help her lung function. And she has a respiratory physiotherapist that sees her every week. But we're still having real problems with secretions, and they are really difficult. So I was interested to hear about this MIE machine. Is it available in the UK? And is it different from what we're using, which is the vest and the LVR bag?
Okay, so before I go ahead, I need to ask you one question. How effective is her cough? Do you think her cough is not very effective? You see the
okay, it varies. If she's very tired, it's not good. I would say it isn't very good. And I've been asking about another cough assist machine because, but the physiotherapist doesn't seem to think it's necessary.
No, I tend to disagree there with the physiotherapist, because I think she will be definitely benefited by use of this cough assist device, because remember we talked about the mucus mobilization. The vest is mobilizing the secretions, but if her cough is not effective, they're not coming out. It's like a ketchup bottle. You're shaking it, but you're not putting it upside down.
It is very frustrating. Yesterday we had a whole day of this happening. We have a suction machine, and we use the the LVR bag. I mean, is that not doing a similar thing? Pushing?
No, No,
Oh, it isn't. Okay,
alveolar bag is opening it's like a lung recruitment, which the machine will
right.
be doing. This cough machine will be doing that also part of, as I mentioned earlier. So I think cough machine is, I'll tell you, I have 200 plus patients with neuromuscular disorders of all kind, including Rett syndrome, muscular dystrophy, spinal muscular atrophy, etc., etc. The one thing majority of the patients say that the boon has been the use of the cough assist device, because the neuromuscular patient, the cough mucus extraction is more important than mucus mobilization. No? So, and we don't want to use the thickening agent, like people try to use, agents which are thickening the secretions, that will cause more problems. So from my point of view, yes, you need to use the cough assist device.
Yeah.
And
Sorry, the other thing that I'm not sure about, carbocisteine she has, you know, what do you think about the use of that? She has that, I think, 3 times a day.
what is that?
It makes the mucus more runny.
No, that's fine. Oh, you can acetylcysteine. Yeah, you can use that. That's fine. But at the same time, main problem is till you use the cough assist. I mean, bottom line, use the cough assist device.
Yeah, thank you.
You
I mean,
will be really seeing gratifying
thank you.
results.
This is what I've been
Yes.
thinking and mentioning so many times, but I'm getting a bit of resistance about that.
No, that's
Because
why I put those, I put those articles there which we published. And we have done this other guidelines also. If you go to our College of Chest Physicians, no, first was the ATS guideline, which we did 2002 for the neuromuscular disease.
I'll have a look at those.
Yeah, and then this one will be published very soon, in few months only.
Great. That would be
And
really helpful.
Yeah,
Really
because
helpful.
all these things you need, because that's what we always struggle with this, basically.
The other thing, I mean, I on your slides, you didn't mention, which I think people don't like to hear very much, but respiratory problems and pneumonia is one of the major causes of death in Rett syndrome. And I think it's a really, really important, and I was really pleased to hear, I wasn't in Nashville, I missed your presentation, to hear that actually you're doing some work on this, because prior to that, it just seems to have been overlooked, or it's only mentioned as when you're talking about breathing difficulties, but it's a major problem, particularly with older people with Rett syndrome, major cause of death.
So true. Yeah, and they land up with major complications. I have patients who are doing very well, where parents decided to have a break because they went for some holidays, left the grandparents to take care of the child, and they were out of their love and affection. They tried to feed this child, and the food going wrong way. Child ended with respiration pneumonia. And believe it or not, I'm not exaggerating, she was on ventilator for 4 weeks.
Oh.
And
I can believe it. I really can, but I think we need this knowledge, and I think it needs to be spread wider and stronger in the Rett community. I really, I really think so.
Yeah, make them watch my video, the recording today's recording.
Well, I've been taking screenshots of all of your presentations I've been going through. It's really important. Thank you. I don't want to take up people's time just with my problems or my daughter's problems. But
Yvonne, I'm really grateful that you asked that question, and I hope it means that other people will be free to also ask questions. But one thing that I wanted to, because I think we can all learn from other people's experiences, I just wanted to clarify for a minute for people, because sometimes maybe I think people don't understand. If somebody's already using suction, why is it better to have the cough assist machine?
Okay, the cough suction is sucking out secretions from the mouth only. How deep you can go, and it is like a bottle again, and you want to suck out the secretion. Yes, you can drink it without tilting it to a certain level, but beyond that, either you use a straw to empty this bottle, or you put this bottle upside down and you drink it that way. So that is a difference, because the suction is definitely, I mean, you need the suction, because if they come in the back of the throat, patient can't cough it out, you have to use the suction machine. But suction can't go to the deep part of the lung, and the actual action is in the deep part of the lung where the air exchange is happening. So you are If you don't do that, you are interfering with and that's how they'll end up with the respiratory insufficiency or the respiratory failure and the pneumonia, etc., etc. Okay.
That's great. Thank you very much. And has anyone else got any questions before I start mine? Yvonne, do you have anything else you'd like to ask or add?
No, I just need to do a lot more reading, and our daughter actually is also at the Royal Brompton Hospital in London, and I think I need to share that information with them as well.
One thing that I'd like to ask Dr. Sharma
Yeah.
is, because I think that Yvonne is actually the founder of the other Rett organization in the UK. So Yvonne's daughter's experience of the sorts of specialists she's seeing and is probably not representative of what most UK people are experiencing, and which is really difficult. I think that I'd like to ask, why do you think it is that in conditions like Duchenne muscular dystrophy or some of the other problems that you deal with, those patients have more active protocol in terms of managing, preventing respiratory infections than we do in Rett syndrome? Because it seems to me that patients with Rett syndrome are just viewed as having unusual breathing, but until they have a really acute respiratory infection, nobody ever puts any protocol in place, typically.
There are three things I can think of. Okay. One, any disease, whether you're talking of muscular dystrophy, or you're talking of cystic fibrosis, or you're talking of Rett syndrome, who initiates the process is the parents, is the family. The first guidelines which I am talking, we published in 2002 through the American Thoracic Society, who supported our study, Parental Project. It was called Parent Project. Cystic Fibrosis Foundation, who started cystic fibrosis? They were the group of parents in Cleveland, America. They started that. Rett syndrome, who is starting? You are the one who is starting the organization. No? So that's one thing. Second, the number of Rett syndrome, remember, in order to collect 700 patients, we had to go to 5-6 countries. We were adding, we started with 3 countries, 4, 5, went to Australia, New Zealand, Germany, Holland, England, and America to get those. So number is very small. So we need bigger voice in order to make it apparent to others actually. Okay. And the third thing is that the Rett syndrome, people think of low tone, which is not a big deal for them, and muscular dystrophy, muscle weakness. But you think of how many patients all patients will need the wheelchair at some stage. They can't speak. They are not growing because of the low tone. So the emphasis is, it's little possibly less, has a less impact on people because we talk the low tone versus the muscle weakness, and the contractures and all, they are more obvious, which is not very common in our patient population, Rett syndrome. But at the same time, yes, I think these are the three things. The main thing, I think we're on the right track. It's just a matter of time and creating awareness. If I tell you, when we started all these projects, people were frowning at us. When I went to the neurology people, I said, okay, I'm a lung specialist and I would like to share and do something for your patient. They look at me and say, what are you going to do for our patients? Because they're not used to those things. So it's just creating, like, we are on the right track, basically. It's a matter of time.
I'm just wondering if, and this is quite, cheeky thing to suggest right now, but I just think maybe this year, even though it's already September, for October Awareness Month, we could just do some awareness cards for people, which we could collaborate with Rett UK on, and there'd be awareness cards about respiratory issues, because the more we speak about it in a collective way,
You're right,
further than info will go.
I think that would be really good. And I think if you could give some references to Dr. Sharma's work,
Oh yeah.
so people could read more, Rachel, as well. I mean, if you keep it simple to start with, but then give links to more detailed reading.
Yes, I think that's definitely a great idea. But Dr. Sharma, one question I wanted to ask you. So as a country at the moment, we're going into a cost of living crisis where there's quite a surge in electricity bills and gas bills.
Oh,
And
yeah.
I was reading in the newspaper a couple of days ago that this actually has quite, if people turn the temperature down in their houses, that what an effect that might have if a child already has respiratory problems. Could you speak to that at all? Because I'm not sure that's something that people are aware of or how to.
I think it'll depend upon how much low you are going to go down. Okay. And do you have any kind of a compensatory kind of a things there? Let's say you cover the patient, you make sure the coverage is very adequate there, or use some other alternative methods like a hot water bottle or whatever to keep the skin warm. But definitely those things are, and if you don't consider those things and go lower and lower, yes, it will have adverse effect there, unfortunately, you know.
Okay, so basically it's not just about the, because I was thinking of it, what made it come into my head is when you were talking about areas being poorly ventilated, but
Yeah.
it's not about the air being warm, it's about the person being warm.
Oh yeah, definitely, yeah.
I see Jill, you've got your hand up. Would you like to? Yeah, go ahead.
Hi there, hi, sorry to be a pain. So we're right in the middle of this situation at the moment. So Millie went into hospital, and I'll be as quick as I can. In April and May, she spent a number of weeks in hospital. And in that time, she lost her ability to eat. So my questions are, can this process happen very quickly? She's eaten orally forever. She's been brilliant. She's used her hands to eat, but she seems to have lost her ability to orally eat almost overnight.
It depends upon what was the reason that time, because I have no idea what happened that time, but it can happen, unfortunately, you know, it can happen. And that's why, remember we talked about the worsening can happen at any stage, and so that's true. And now we need to make sure that we have some plan how to feed, and whether if you can't eat by mouth, or if it's going wrong way, then you have to use those G-tube. And I know its whole concept is changed suddenly, because certain kind of food you can't go by the G-tube, and you have to liquefy that, puree it, and certain things you definitely. So I understand that, but it can happen. I've seen that happening. And but at the same time, one thing I can assure you, seeing so many patients with the similar kind of a problem, that at the end of the day, after some time, you get used to it and you don't feel that bad as you're feeling just now.
Yeah.
I think
can I just endorse that, because we had that problem as well, and we found it really difficult to come to terms with the gastrostomy. But actually, if you look at our daughter now, she looks so well, and she's totally peg fed on formula, and it's not what we would want, but it's actually been really good for her, and it saved her life.
Yeah, absolutely. And I think it's been a process for us. So
it's a horrible process.
It's awful because there's such emotion attached.
It is.
It was the one thing that she really enjoyed.
Yeah.
The one question I didn't get real clarity on was whether the cough assist machines are available in the UK, because we only have suction at the moment. And although we're trying lots of things, we've got the hyoscine patch to try and secretions. We only at the moment at home have monitoring, of course, and the suction machine. I don't have any cough assist. And we're using the suction to induce a cough, which I know is not right.
My guess is that it will be available there. It should be available because it's not a big deal, because this is a big company. Multiple companies are making cough assist devices.
Okay.
And Hillrom makes it Vital Cough. There is these guys, they make it like this cough assist device. So I'm sure they are, but it may be kind of, we may have to look into that.
Yeah.
And if you are interested, I can kind of inquire from our local people here. Just you drop me a line and I can ask them and connect you to those guys, and they'll have some international supply, because I have arranged these devices as far as in India, and it was different device, but definitely there was one supplier, one distributor, and you have to chase him or whatever. But I think I would be thinking that.
We do have them. I can assure you we do.
Yeah, that's good.
I've sort of looked into this already, but you need to be, I think you need to be in consultation with a respiratory specialist at your hospital, or and do it through that route.
Okay, so with the respiratory at Alder Hey.
Yeah, and actually, if you want to have a chat with me at any time, please do. I may be able to help.
Yeah, that would be really good.
Maybe been through some of the questions
on Friday as well, so we're just kind of right in the middle of it all. Thank you.
Okay.
As usual, it's, I think, as Dr. Sharma was saying, as usual, it's that you have to ask the question and press for the thing that you think is right, which I think from our end we can probably look at if there's any kind of guidance about when people are offered machines. But as I alluded to earlier, I think they're more readily available for other people. One thing that I really liked was being able to see all of the video of patients using these different pieces of equipment, and especially the bit where the boy was using the cough thing, and you'd shown that he'd had the mobilization, and then they did the cough thing, because the thing that was most striking about that was the joy on his face when he had been able to cough, because he must have had that really suppressed feeling of that being stuck there for a while.
You're right.
That was brilliant.
I had a question, Dr. Sharma, because as we've talked about, nothing seems to really happen in this country until you have a chronic situation in terms of respiratory problems. What therefore, you're not going to get access to machines or devices until you have that kind of situation. Is there anything that you can be doing before you hit that point? What kind of preventative things in daily life, other than, I know, just keeping your child upright and active is useful, but is there anything else that just can be integrated into daily life without you needing this chronic situation to activate maybe more advanced things that we can all be doing?
You know what? Key thing is involving people like lung specialists who are intending to be involved and who are providing the anticipatory guidance. That's what I meant. Because when I see a patient is fine, eating, drinking, everything is fine. But I tell them, listen, with the time, this is going to happen. And when this happens, we are going to be intervening, basically. And not only that, when we are seeing them, we are monitoring them. We have devices which monitor the cough peak flow. I mean, how much air is coming out of the, and then you'll not believe how much we have to fight. I have a nurse, virtually her job is just to fight with the insurance companies. So you think that America is very good there? Oh no, this is disaster. They have taken away devices from my patients' home, basically, because there was some issue. It was so bad. Here also same thing. But the only thing is that it's our involvement is not only intervening when it is needed, but making them aware and acting in a very timely fashion so that it's not too late that time.
Yeah,
that's what I will suggest.
Yeah.
And this is spreading now. I've been involved in these sessions across the North America for a long time, going to different places, giving lectures and all, and you see some kind of a very kind of situations, similar kind of situation that nothing was done, and once you start, the things start changing. So it's just creating awareness in the not only in the patient population, rather in the providers population, also the physicians, etc.
Yes, yeah, because I was interested to hear that you recommend seeing a respiratory team almost as soon as you're diagnosed, which I don't know about anybody else, but that certainly wasn't. We had to wait before my daughter had pneumonia. That was the first time we saw anyone to do with respiratory problems, and I think that's fairly common here. So it's interesting to hear that. I mean, it makes sense to all of us as parents that should happen at diagnosis, but it isn't embedded in our system yet.
Right.
So we come back to Yvonne's point, I think.
Yeah.
It's very interesting. Has anyone got any more questions for Dr.
No, but that's been enormously helpful for me. I've been worrying about this, for so long, and yesterday was really bad with Claire and I, so it's given me a way forward again. It's given me a plan, and I think that's what we all need when we're feeling a bit hopeless. I think if we have a plan, it helps.
Yeah, I'd like to know how you get on, Yvonne.
Okay.
Yeah.
I mean, Claire is a bit of a trailblazer because she was one of the first Dr. Sharma in the UK to have a diagnosis of Rett syndrome in 1985. So, we're learning. We're learning as we go up.
Which is true. Basically, 100% true. It's just a matter of time. Hopefully, people will be more aware of it and more willing to be kind of intervening earlier and earlier.
Yeah, but thank you for all your work. And thank you for your interest.
No, thank you.
And thank you for just being willing to home in on Rett syndrome in particular for us today as well. We just really appreciate it, and hopefully
it was my pleasure. No, I really enjoyed it. Okay, interacting with people. Yeah, definitely.
Thank you.
Brilliant.
And thank you for leaving your email address on the last slide. So
yes, absolutely.
If anyone thinks of any questions, you might get some, especially once we put the recording out to everyone who signed up but couldn't make it, you might get some extra questions.
Dr. Sharma, would you be willing to talk to if he was willing, our daughter's consultant, respiratory consultant?
If there's a need, I can definitely. If there's a need, I can talk to them.
That would be really helpful. That would be really helpful.
Yeah, sure. Yep. Okay.
Yeah. Okay. Well, Dr. Sharma, thank you again so much. Again, especially for coming on what is a bank holiday in America.
No, don't worry.
Appreciate it.
It was a joy for me. No, I was looking forward to it. Don't worry. So Beth, you'll be sending me the link for the recording also. Okay.
Yeah, absolutely. And we will all be taking that forward and learning from today's presentation. Thank you, and thank you everyone for bearing with us for the technical difficulties at the start.
No, sorry about those technical difficulties.
No, not at all your fault. Thank you.
Thank you, Dr. Sharma. Enjoy the rest of your day and having a holiday. I hope it goes well.
Thank you very much. Thank you. Really appreciate
Thank you, everybody.
Bye, everybody.
Thanks, everybody.
Bye.
Thank you.
Bye.
Bye-bye.
Bye.